I'm Kate Ryder. I'm the founder and CEO of Maven. We are the largest virtual clinic in women's and family health. I started the business about 10 years ago. And what we do is we cover fertility, maternity, pediatric, and menopause benefits for about 23 million lives around the world. And really the mission of the company is to bring better access to care. And so women have historically been underserved and underfunded. There's not a lot of research or even protocols in areas like menopause for what to do. And so that's why part of what we do is we have the largest telemedicine network in women's and family health. And then we have market-leading fertility benefits. So we help families go through IVF, IUI, adoption, and surrogacy.
Great. John Love from Amazon Pharmacy. And the U.S. healthcare system is about $5.4 trillion a year. That makes it top 5 GDP in the world. And our lifespan and health span have not improved. And so if you drill into pharmacy is about $700 billion a year. And the pharmacy that is closest to me, and I live in a nice area, the outside of the building has a, gonna get a different mic here? Sure. The outside of the building has a Redbox video rental and a 1-hour photo delivery. And so the pharmacy experience for most people is you go in, you have a private conversation in a public space, you have no idea what meds are gonna cost. So we're building nationwide medication delivery where the pharmacy is in your pocket. You can look at it any time of day that works for you. You can call and have a pharmacist talk to you. You can see the price of your medications up front, and you get them delivered to your doorstep. And so what we really believe we can solve is access and affordability in medications.
Very good, some through lines here. Cory Warner, I lead Uber Health, which is the team at Uber that thinks about the intersection between healthcare and technology, and thinking about how do we leverage the platform and the scale of Uber that we all know and love today as the on-demand service, go anywhere and get anything, and apply it to healthcare. And so within the healthcare space, you think about the billions of dollars spent across the ecosystem for missed appointments. 2 out of 3 missed appointments are due to lack of access to transportation. And so really that's the problem we're aiming to solve, and do so in an affordable, available, accessible way. Most people know of Uber as the app on your phone, in your pocket, that you can pull out in a moment's notice and book a ride to the airport to work. But what we offer is access to that same platform through a platform that we can give to our healthcare stakeholders. So we work with 4,000 plus healthcare organizations across the country, from hospitals to clinics to non-emergency medical transportation brokers to specialty benefit managers, and give them access to this platform so that they can, in the same way that you and I do, have on-demand access to care.
I think you've got my same mic.
Sorry, it's always awkward when this happens at the tech conference, but one thing at a time, so we'll panel on microphones next year. What I was trying to say is, I'm intrigued by what you're saying. It sounds like to be more bespoke, cheaper, and easier to get to. But also my very limited knowledge of healthcare is there's a lot of records, and it's just kind of Tower of Babel. You've got to plug into United or whatever the insurer is, and this and that. And for this to function efficiently, don't all you guys have to be able to plug into this stuff too? And how hard or easy is that? Why don't you start, Cory?
Yeah, I would say that it is a challenge. It certainly is thinking about, do I have a ride? Is it covered by my health plan? How many rides do I have? Where can I go? So what we do is we think about how do we plug into the ecosystem that exists today versus creating our own new separate way for someone to access care that doesn't fit within the confines of their life. And so whether that be plugging into a hospital where they may have the funding mechanism themselves that they care to pay out of pocket to get someone home because the cost of the $20 Uber ride home is more effective than a bed that they couldn't put a patient into, that plugs right into the actual ecosystem of a hospital. Or working with a non-emergency medical transportation broker who already has the mechanisms to validate that that ride is covered and make sure that that patient gets to where they need to go in accordance with their particular health plan benefits. I think our aim is to simplify the process and make it streamlined for not even just the patient, but for actually the stakeholders involved that care for the patients, to give them the time back that they want and less on the administrative burdens.
Yeah, and I would just say one of the changes we hope to see in healthcare is to become more federated so that you could link together the providers and the services that you want. Some of those might be local, some of them might be virtual, and be able to connect those for your care. That's really, really hard today. I had my knee looked at one time because I play sports with too much energy and too little skill. And I went to the doctor, and they're like, well, did you bring the disc of your MRI? I'm like, I didn't know I had to go get a disc, and I have to carry that around with me. And so what we need is the ability for these healthcare entities, pharmacy, for example, should know what's on your formulary. Like, I don't know if everyone in here knows, you get a mail order benefit, a retail benefit, a specialty benefit, Part D, all of that has prior auth. It's incredibly confusing. But those plan beneficiaries don't share that with the provider or the pharmacy often, so you end up in these spirals of prior auth, and that's part of the reason. A huge portion of the cost and the quality of care, it's just defects. It's weight and waste, and it's miscommunication. So what we're trying to do is make it easier to connect entities for the same care of that individual.
Yeah, I mean, it's funny, right? Because ever since I started 10 years ago, everyone's been saying the same thing. It's horrible, we can't connect anything, and people have been saying, oh, but consumer health is here. And I think for the first time, I genuinely believe consumer health is here because you see Amazon on stage and Uber on stage, and there's finally, I think, with AI and the abundance of data and the fact that the system and healthcare inflation and costs have been rising so dramatically over the last 3 to 4 years, the system can't take it anymore at the same time as technology is now finally empowering the consumer to really take control over their own data. And so you have all of these things like, these trends right now, like the use of wearables, the ability to just get blood tests really easy, the ability to get, pharmacy really easily, and the ability then to collect it all in one place to proactively manage your own health. And so I think finally, for the first time, we can start to kind of untangle it, because for the first time, the payer, and you can look at the share price of a lot of the payers are a little bit on their back foot because the current system as it is not working, at the same time as AI is coming into healthcare in a really exciting way.
I'm sure we have some folks in the audience with great questions, so I'm going to ask one more, and then if you have one, please tee it up for me. But we're talking about data there, and earlier we had the CEO of Ura on stage saying some intriguing things on that, resolutely will not share their data with, with third parties. And, it seems especially fraught right now, too, with the litigation over, abortion and who's, getting that, and states making demands and stuff. And so I think trusting our consumer data to more entities, including, Uber and Amazon, which are big data players, how can you assure us our data is safe with you? Do you want to lead with that, John?
Yeah, sure. One, data is a non-negotiable red line in healthcare, and it's person-centric. So if you look at Amazon Pharmacy, you actually go into the Amazon app, and then you log in and securely go into pharmacy. It's a person-centric experience. So we've got a lot of expertise in protecting data, and it will be a reason sometimes we have to tolerate a little more friction, a multi-factor authentication sign-on to make sure that you're you. However, it needs to be both. We need to do a better job of protecting data across healthcare, but we also need to share it in the service of a patient. If someone's got an allergy, if they've got a health condition, if they've received a lab, everyone in care of that patient should be using that information to improve the quality of care. So both need to be true. You need to have the highest bar, but you also need to link data that is critical to care.
How about you, Cory? I mean, Uber, sorry, doesn't have the best reputation with this stuff. You know, you haven't done anything bad for a few years, I recall, but, you know, how can we be confident that we can trust Uber with our health data?
Yeah, I think if you think about it from Uber's perspective and then Uber Health, at Uber, data protection and privacy is paramount. We operate in 70 countries and 10,000 cities, and so it's a global business, and we have, you know, people and things moving all over, and it's paramount that our teams are operating in a way that thinks about the end user and protecting the integrity of the relationship and the trust that we've formed with our consumers. The same thing applies when we think about the healthcare organizations and the patients that they serve. Even more so, we separate the data that we have for Uber Health from the rest of our Uber business and Uber for Business, which serves business stakeholders and entities, because of the encryption and requirements needed to manage healthcare data in a different way than the rest of consumer data. But overall, the aim is to have the same protections that's required of us and then some.
And how about you, Kate? I mean, being a sort of a smaller entity, you know, I think it's less the risk of you selling the data than getting hacked. Oh, of course, big entities like United have been hacked brutally. What do you do to sort of the cybersecurity challenge? How can we trust Maven?
Yeah, I mean, I think it's a huge investment area, obviously, on our engineering team. We have great people working on cybersecurity, and so I think the way we think about data is, you know, we have to go, we have about 2,400 customers, and we have to go through, Amazon being one of them, their own cybersecurity tests. So, you know, all the major payers. So I think we've been pretty well tested through all of these implementations. But I think the one thing I will say is what John said is so important, is actually we just see patients really frustrated that their data is so fragmented, and they do want all of the right providers kind of sharing it with each other. I also think as a women's health company, we empower choice. So sometimes our patients don't want their data shared, and that's also fine too. So it's important in a connected ecosystem to also empower choice.
Go ahead, sir. Please introduce yourself and keep your question crisp.
Sounds good. Sounds good. Dominic with Forge. Two-part question. One is around consolidation. So it surprised me that Amazon bought One Medical for $3.9 billion in 2022. And then the second question is around kind of the current administration's views on pressuring drug companies to make prices lower for the U.S. consumer, and anyone can answer that.
I can take the first one on Amazon here. Yeah, so primary care is really the front door of healthcare. It accounts for a relatively small percentage of the spend, but it helps a huge amount of patients navigate care. And we really like the One Medical model of the fact that people came in, it's access-based. I talked about access and affordability. You can get seen. In some cities, people are waiting a month, 2 months to get in to see a primary care. The other thing is One Medical uses technology behind the scenes and a central group to help, such that when you're there, you spend full time dedicated with that provider. So they're listening to you, they're engaging with you. In some major health systems, you might be running through, it usually starts with a paper form you fill out, and then you kind of get passed through folks. And so that was what was really exciting. We love the care model of One Medical. It is also separate of Amazon pharmacies. So a lot of One Medical members choose to go to a neighborhood pharmacy. If you happen to have a great independent pharmacy, that's excellent. A lot of Amazon pharmacy folks get care at other places. So this is that federated model. You know, you could be a Maven member and choose to use Amazon. I actually think it's really important that customers have choice and transparency. You talked about data. Like, it's hard to navigate. Who's in my network? Do they, you know, who can help me? How much is it going to cost? That's what people really want. And so the model that we're looking for is a federated model where you could use local service, national services, startups, large entities, and be able to control kind of who's in your care team.
And I will say on the drug question, about 10 years ago when we started in the space selling to employers, you know, prescription drug spend was about 10-15% of how much employers were spending every year, and now it's almost 30%. So the prices are out of control, and I think that if the administration is successful, it will benefit everybody. I mean, I think if you look at GLP-1s as an example, you know, everyone in Canada and Europe pays way less than Americans. America, we're basically subsidizing a lot of low drug prices around the world. In fertility, as an example, So in the last 10 years, fertility drugs have risen by 84%. Fertility drugs make up almost 35% of the cost of someone going through IVF, and is one of the big reasons that IVF, the costs are prohibitive. And you can kind of look at that in specialty across all drug categories. So 90% of drugs in the country are generics, and we have the best price. But in the specialty market, which is about 10%, it's like 10x, 100x what everything else is. And so we experience that in fertility, and I hope the administration is successful in getting better drug prices for us.
Yeah, go ahead.
Hi, Emily Sherberth with APCO. We do communications and advisory work. This is mainly a question for Key, but I'd love to hear what the other panelists have to say. Technology creates greater access to care. Health equity is really important. I know Neil Shaw, your chief medical officer, is very passionate about this topic, talks a lot about the Black maternal health crisis. Can you talk, each of you, about how you're addressing health equity with your platforms?
Thanks for asking the question. No one asks it these days, so it's good. It's good to hear it again. Health equity, particularly in women's and family health, is critical. So yes, like Black maternal health, taking that as an example. Black women die at 2 to 3 times the rate as white women in childbirth. That is in the postpartum period as well, in the first 52 weeks after having a child. That's unacceptable. That's a health equity issue. And so as you design care models, and Maven is fundamentally a care model, you have to take into effect everyone's lived experience and their background. And so I think for us, for example, in our telemedicine network, we make sure we have diverse providers. There's direct correlation between Black patients seeing Black providers, so that's one way in terms of driving better outcomes. We have, when people are coming into our program, we ask 3 questions around kind of somebody's situation, the social determinants of health, they're called. You never hear that anymore, using all these buzzwords of 2023. But really, really important, because if someone, as Cory was saying about Uber, if someone doesn't have transport and they can't get to their doctor's office, that's an example of a social determinant that will inhibit someone from getting great care. And so all of this has to be looked at if you're trying to drive better access to care, and it's what, a lot of what makes up health equity. And so if you're in, I'm sure John and Cory have a lot of what you do, so I'd love to hear that. But yeah, thanks for asking the question.
Yeah, I would echo a lot of what you're saying. And thinking about underserved populations, those are the populations that we serve the most. And oftentimes people think, well, isn't that hard to think about plugging a technology into some of those populations, depending on, do they have access to an Uber? Do they have the ability or the means to do so? And one poignant example that I think of is our partnership and work with the Veterans Health Administration. I talked about billions of dollars spent on missed medical appointments. Well, they stated that $4.4 billion annually is associated with missed medical appointments. And so that's just one entity of a number, and one that has certainly a population that has unique needs. And so they were hesitant to think about, how do we incorporate Uber Health into our workflow and to serve our population. And so when we implemented the Uber Health program across a number of medical centers, what was interesting to see was the feedback that we received from veterans themselves, their ability to feel like they had agency and the ability to feel like they were able to have autonomy. And some of the feedback that we received through the New England Journal of Medicine, the article that they published on the work that we did, was 80% of veterans stated that if they didn't have the Uber Health program, they wouldn't have been able to get to their medical appointment. And 9 out of 10 veterans would refer another veteran to the program. So just showing that there is applicability of this kind of technology across a number of different types of populations and peoples.
Yeah, and I'll just add on, at Amazon, we focused on affordability. We created 3 programs for pricing. One was RX Pass, which is a formulary. It's a list of 50 common generics. It's $5 a month. And 75 million Americans take that. And so what you see is people who don't have health insurance, have high deductible, we over-index on cash because they realize for $5 they can afford their medication. And then we work directly with life sciences and pharma, to your point on the 10% that drive the cost, to create coupons. And so most notably when insulin dropped, you could see insulin and get it on Amazon at $35 without having to go navigate and find discount codes. The others is just delivery to the home. It's a mobility challenge. And you might work 2 jobs or not have a convenient time to go to the pharmacy in their hours. So being able to do things anytime throughout the day and have medication come to you, these are the things that we see tipping the scales.
We're coming to a close here, and I'd like to end, Sir, very quickly.
Yeah, just how do you resolve, virtual care, but not remove the intimacy of very important health decisions? And how do you remove or make the pharmacy more accessible when in many places in America, the pharmacy is the one place where people go get their health care? The pharmacist might even be the person who's kind of proxying as a doctor. Because I fully want the model, but how do you guys resolve those issues?
Well, I would say on the pharmacy side, it's not a either or, it's a both. I think a lot of care is going to be virtual, but there will always be in-person care too. You can talk to a pharmacist on Amazon Pharmacy, so we allow both of those. As a matter of fact, I've called them late at night for my son when he's going through a procedure. And so I think you're going to see a development of both. Some people will want to go in and see their pediatrician, or they'll have a lovely specialist they want to work with. But they'll also get a sinus infection or a UTI or have a private health that they want to get issue they want to get dealt with virtually. So I think these two are going to be in harmony, and we need to find reimbursement models and access models so you can go get seen when you want to be seen or need to be seen, and you can have kind of a very private, convenient, transparent experience for other times.
Okay, do you want to add something real quick?
Sure, yeah. You have to remember in women's health, a lot of the providers weren't in the care model in the first place. So doulas, pelvic floor therapists, lactation consultants, it's a health equity issue, right? And so, OBGYNs that know how to speak about menopause. And so I would say, for us, we just play in a gaps in care market in a big way. And so and then we also work with so many moms that are really, really busy and don't have the time to go in. And so what we find is that our patients actually most often prefer virtual care. In at least in going through fertility journeys and going through pregnancy and postpartum and menopause, because they find that the providers take the time to listen, and then the providers are types of providers that they don't have access to normally.
My last question, let's turn into a lightning round. I think most of us here believe tech is a force for good in our lives in many cases. So what piece of medical technology is going to change our lives for the better the most in the next 5 years? And very quickly, please, go ahead.
Wow, that's, I was talking to some folks beforehand who are trying to convince me or others to the Oura Ring, so that's an interesting angle. I think it's honestly those things that are simplistic that are the pieces that are the most impactful. And so thinking about making benefits universal in a way that people have options. So I really like the idea of flexibility, whether it be for a flex spending account or through the opportunity that you have with an employer that offers some kind of flexibility of where you place your dollars. There's simplicity in that, but it allows for catering to someone's unique needs. And so I think that's something we should lean into across the board.
Great. John, very quickly.
Yeah, I think the ability to link data from biometrics and labs and engage more on preconditions, cardiometabolic health, prediabetes, like these are major disease states that we could dramatically reduce, prevent, and stave off. And we're getting to the point where we could have the technology. Your pharmacy could look at your A1C or your blood pressure and suggest a titration. And that would be a very light, small, easy thing to do that would have a very material lift on health.
That's exciting. And Kate, take us out. What's the most exciting tech for you right now?
I mean, echoing what John said, but I'll go in the fertility space. The robot embryology labs are really cool. So look up a company called Conceivable. Embryology is one of the biggest things that drive outcomes in IVF, is getting the embryology lab right. But right now, it's super manual and crazy facts. But an embryologist who looks at an embryo at 8 a.m. is more successful than an embryologist that looks at an embryo at 2 p.m. That's how bad it is. And so there's a lot of robots and AI that are coming to make embryology as perfect as it possibly can be in an IVF cycle.
Fabulous. Okay, please give it up for our great panelists and stick around for our closing ceremony.